Good morning or evening or afternoon, wherever you are around the world. Welcome to this morning's tumor board session from Thyroid, our multidisciplinary team. We're very privileged to have Dr. Rossella Elisei with us from University Hospital in Pisa. That's a friend of many of ours. We have an international panel of panelists with us here this morning, and we'll go around. I'll have everybody just introduce themselves really quickly. I think we should always start with the pathologist first because they're the key to this. Dr. Brandwein?
Oh, thank you so much. I'm Margaret Brandwein-Weber, and I work with Mark Erkin.
Oh, you poor thing. Dr. Shon?
Hi, Ivan Shon, nuclear medicine and pet physician, Prince of Wales Hospital, Sydney, New South Wales, Australia.
Welcome. Dr. Khorsandi?
Azita Khorsandi, Mount Sinai. I work with Margaret Brandwein.
Now we're talking. Dr. Wirth?
Hi, everyone. I'm Lori Wirth. I'm a medical oncologist at Mass General in Boston.
Fantastic. Dr. Cunningham?
I am an endocrine surgeon. They allowed the surgeon on the panel, and I work with Lori Wirth.
That was a scheduling error, but we're doing our best. Dr. Pitoia from Argentina?
Good morning. My name is Fabian Pitoia. I'm an endocrinologist from the University of Buenos Aires, Argentina.
Perfect. And Rossella, let me have you introduce yourself with 2 or 3 sentences, and we'll bring your first case up while you're talking.
Okay, I'm Dr. Elisei. I am endocrinologist, but I am mainly involved in thyroid cancer diagnosis and treatment since many, many years. That's it.
Okay, let's start with your first case, because apparently you know a little bit about calcitonins and evaluating thyroid nodules and have been trying to get me to change my mind for about 15 years. So let's see how you do this morning.
I know much more or less the same that you know, but probably we have different opinions on calcitonin. So we will see what I'm trying to demonstrate with this case. So go ahead. So this is the case of a female, 50 years old, who arrived, who started in March 2009 to perform a neck ultrasound, and some nodules were discovered. Go ahead. So she performed also a thyroid function analysis, and antibodies were at high titer, so the diagnosis of Hashimoto's thyroiditis was performed. Neck ultrasound showed the presence of 3 nodules. 2 were very small, 1 a little bit bigger. So what to do at this point? What to do to this patient?
So Fabian, let me have you start there for a second. Just sort of where do you start? Sort of how do we do this in Argentina? Then I'll come to you, Carrie. Fabian?
I think with this patient, we have a low risk, at least considering the last published American Thyroid Association guideline and considering the thyroids also. So we know that the risk of malignancy even may be lower than the previously published with the new guideline that is going to be published soon with the data that were presented, and maybe between 3 to 10 to 20% the risk of malignancy of these nodules. So probably in Argentina, what we do is really discuss with the patient what the patient wants also, not only the risk of malignancy and how the patient can live with this uncertainty of 3, 10, or 20% with the smaller nodules. Probably we'll go with the final aspiration of the larger one, but if the patient wants to really, really very uncertain or unsecure with not knowing the etiology of the other ones, we probably will go with the patient and help him to reduce this anxiety. So we discuss all these things with the patients, and then we move for fine needle aspiration, probably for the largest.
So Carrie, since it's just the 8 of us here, nobody's really kind of listening, tell me, what do you really do? Do you use TIRADS? Do you use ATA risk? Do you just look at it and decide? I mean, what do you really do when you're in clinic?
The TIRADS are given to me. But honestly, I based it on my own ultrasound, whether or not I agree with the thyroid. Not that I'm better than a radiologist, but I look at all the nodules and I'm less worried if there are more nodules, right? If this is looking like a benign multinodular goiter. And just as Fabian was saying, I would definitely have a conversation with a patient about how comfortable they would be with watching. I don't know about everywhere else, but I have very few patients who are comfortable just watching and waiting.
Okay, Dr. Elisei, keep going for us.
So what we did, we decided that is something that we do in our hospital, at least I won't say in Italy, but I won't say just in our hospital. We did not perform fine needle aspiration on the smaller nodules, but we did a fine needle aspiration of the bigger nodule. Go ahead. Again. And this is because, as we know, according to the guidelines, small nodules less than 1 centimeter should not be punctured. And we followed what American guys and American colleagues say. So we did not perform fine needle aspiration of smaller nodules. Go ahead. And according to the risk of malignancy, the only one that we punctured was the biggest. Go ahead. And this is because both in American Thyroid Association guidelines and also in the European NEC ultrasound stratification risk, for nodules a little bit bigger and with a iso hyperechoic features, there is a small but not negligible risk of malignancy. Go ahead. So this was the nodule. You can go because we already discussed about this, and we puncture, and this was a benign nodules. What about calcitonin? you know that there are a lot of different opinions in measuring calcitonin in all nodules as a screening. And in some guidelines, it is considered to measure calcitonin only in patients who undergo surgery or in patients, go ahead, with indeterminate cytology. Go ahead. However, as Mike said, we have an old and quite big experience on measuring calcitonin in nodules as a screening methodology, and we demonstrated several years ago that by measuring calcitonin in nodular goiter is helpful in detecting medullary thyroid cancer when it is still small and intrathyroid, thus improving the outcome of the patients. Because as you know, medullary thyroid cancer can be cured with surgery only if it is still intrathyroid. Go ahead. Nevertheless, at the first time, at the first visit, the calcitonin was not measured. Go ahead. Sorry, was measured and was in the normal range. So we start the annual examination with the thyroid function control and neck ultrasound. I don't know if everybody agree with this kind of follow-up for this kind of small goiter, small nodular goiter.
Yeah, so Carrie, if you had one of these that had the couple nodules, the biopsy looked good, what's your real follow-up look like? Sort of, this is going to be obviously a crazy case because it's a panel, but in a real person.
I know where this is headed, but in the vast majority of patients, I would be very comfortable with that. Again, I would assess the patient's anxiety about how long to look at it. So annual exams are fine. And in fact, when I've started doing every 2 years for patients I've seen for a couple of annual exams, just because I think it actually causes them more anxiety to come in. And if they're not growing, then I actually switched to 2 years now.
Yeah. And Dr. Pitoia, do these people ever get out of your follow-up? I mean, some of these patients we followed for 5 or 10 or 15 years and not much is changing. Do they keep coming back at long intervals, or do you ever get them out of your practice?
Yeah, I think probably this will change in the near future with the new guidelines. But at this moment, we continue following up these patients for all the rest of their life. At least in Argentina, this is what happens. We continue seeing this patient probably every 2 years, then when we do not see any change. But this patient with the thyroiditis, and we want to know if the patient is going to become hypothyroid, probably we will continue following her every year. Probably in the US, you refer this patient to the general physician and is followed up by the general practitioner, but here we follow as endocrinologists these patients.
Carrie, let me ask you a related question. Rossella's talking about serum calcitonins and screening for the nodule. Any role for washouts of calcitonins, that sort of stuff in your practice? Do you tell me a little bit about that?
Ironically or not ironically, in my research team, I'm using a microsimulation model for the entire population of patients with thyroid nodules. And the question we're looking at is screening calcitonin. You'll be happy to hear, Rosella. While we were looking into this, we realized that FNA washout of the nodule is excellent. And the sensitivity is much higher than serum calcitonin. We have not been doing that, at least in my practice, but I may start doing it if there's a concern for a medullary thyroid carcinoma. So I don't know if anyone else is doing it, but I was very impressed. Small series, of course, but I was impressed with the increased sensitivity. As we all know, serum calcitonin, there are quite a few reasons for false positives, and so it's an excellent test, at least from the literature that I've seen.
So Margie, I'm used to thyroglobulin washouts and parathyroid hormone. Thoughts about calcitonin washouts in nodules or places, or this is new?
Mike, have I ever told you I'm not a cytologist?
Yeah, but I keep asking you the questions anyway. You're a pathologist. Any thoughts there?
Yeah, I'm sorry. I can't share any educated thoughts because I don't do this. I'm not a cytologist.
me neither. That's why I ask you, Dr. Pitoia.
Yeah, I want just to recall, we published last month in Thyroid our paper on washout on calcitonin, and it was really very, very effective. It was led by Andrea Cavallo here in Argentina, and the AUROC was 0.99 with the measurement of the washout of calcitonin, with a threshold of 220 picograms per ml to determine. Most of the thyroid medullary nodules had a calcitonin level higher than 3,000. So and compared to 0.5 to the non-calcitonin nodules. So it was a case control study, and it really works.
And Fabian, are you using it in selected nodules or indeterminates, or?
Well, this was a perspective. It was a prospective trial, so we did it every nodule, even to determine the probability of going to lobectomy in those patients with multinodular Gaucher. So we could define the site of the location of the medullary thyroid cancer and also the proper medullary thyroid cancer.
So now I can say something quickly. Okay, in the words of Yuri Nikiforov, medullary thyroid carcinoma is the melanoma of the thyroid. So it can look like anything, so from a cytologist point of view, I'm sure that could be very helpful.
Perfect. Sounds great. Okay, so Rosella, let's go back to the serum calcitonin story, but that sounds like there's a washout story that's really developing here over time. Rosella, let's keep going.
Go ahead. So she became hypothyroid, and she started the LT4. She was followed periodically for 3 years, more or less. Situation was rather stable. And At certain point, she had a new diagnosis of Crohn's disease. So she stopped the evaluation for thyroid disease, being concentrated on the other problem. Go ahead. She came back 4 years later, and the neck ultrasound showed an enlargement of the biggest nodule and the appearance of a new, very small nodule. So again, at this point, how do you manage these patients? This new nodule or the enlargement of the other nodules represent something that you would consider or not?
I personally would ignore this and go, you've got lumps, you're allowed to have lumps, you're going to have more lumps, go away. And I would probably spend 30 seconds thinking about it, if I'm honest with you, Rossella. I'd say it's the natural history of multinodular goiter, and you're going to tell me what a huge mistake I made. But that's what I would really tell this patient.
Well, not only you made a mistake, but we did a mistake. Go ahead. So we repeated the fine needle aspiration of the bigger nodules because it increased in size, and we thought that would be better to check again. We didn't perform calcitonin again because it was already performed in the past, and we continue the follow-up every 6-12 months because probably the goiter was growing, and we decided to look at the patients a little bit more frequently. So 7 years of interruptions because this long follow-up sometimes has this problem. Patients became tired and they stop follow-up. And in February 2023, the neck ultrasound showed an increase of the nodules that was the new nodule in the previous slide. So what to do now?
Yeah, I think. So biopsy that one, right? I mean, it's been 7 years, but it's gone from 6 to 18 millimeters. You know, I'd biopsy it, expecting it probably to be okay, but probably biopsy.
Okay. And calcitonin, again, it was measured in the past, and we followed the indication that only if fine needle aspiration would be indeterminate of if surgery will be indicated, as several of our guidelines are suggesting. Go ahead. So this is the imaging of the new nodule. That is not very, very good to me. What do you think?
Azita, do you do ultrasounds as well as CT scans and stuff? Can you
Yes.
give me a peek at this one?
You know, it's well defined. It doesn't have irregular borders, is wider than taller. It shows a little bit of increased vascularity, but we don't use that as much anymore. And I use the word generally. If the lesion starts getting more hypoechoic, which was the one she pointed out along the lower pole on the left, then that's the one that worries me the most because it started getting hypoechoic. That's the feature that it's more ominous.
It's going to take us up toward more of an intermediate as opposed to a lower suspicion kind of thing. Okay, Rossella, and when you were looking at these, obviously you get to the ultrasound. What were you thinking here?
Well, this kind of nodule in our center is punctured. It's punctured because it's hypoechoic. There are some probably microcalcification, and we use also elastosonography that was indicating a stiffness of the nodule.
Okay, keep going.
Yeah. So again, this is the risk of malignancy according to the American Thyroid Association. And also for the European neck ultrasound stratification, there is a little bit increase of the risk of malignancy respect to the previous one. Nevertheless, we punctured the nodule, and the response was that the nodule was benign. We didn't perform calcitonin, and we continue to follow up the patient. Then something happened. The lady changed her general practitioner, and it's a real story, it's not fiction, it's a real story. She changed the general practitioner, and we don't know why, but he decided by himself to perform a thyroid evaluation and measuring also calcitonin. And at this point, calcitonin was very high. So calcitonin was repeated because she immediately contacted us, and we asked to repeat just in case it was a mistake or some laboratory problem, but the calcitonin in another lab was confirmed to be very high. So she came back to our referral center. And before going ahead, I would like just to share with you, no, go ahead, Mike, please, that unfortunately, as this very nice study demonstrates, the fine needle aspiration can detect medullary thyroid cancer only in less than 50% of cases. As probably everybody knows, this is an international multicentric study, and the results were very similar in all laboratories that they were involved in the study. So it's not a surprise for me that this lady had a benign nodule at cytology, but probably also a medullary thyroid cancer indeed. Go ahead. And this is another study, is a meta-analysis indeed, demonstrating that the detection rate of medullary thyroid cancer by fine needle aspiration cytology ranged, differ quite a lot in different laboratories, but the median is 56%. And according to what we said previously, the sensitivity of FNAC can be improved by measuring the calcitonin in the washing fluid of the fine needle aspiration. This is another study demonstrating the same concept, and this is an American study in which the authors demonstrated that only 50%, 49% of medullary thyroid cancer were really detected by fine needle aspiration. We can go ahead. And another thing that we recently demonstrated is that neck ultrasound, the feature of nodules of medullary thyroid cancer at neck ultrasound are different from papillary thyroid cancer, and the risk, the ultrasound risk stratification systems are not well defined for medullary thyroid cancer because they have been built for papillary thyroid cancer. Go ahead. And in fact, according to all the different risk systems, you can see that at least in 50% of the cases, the neck ultrasound features do not give indication for fine needle aspiration in medullary thyroid cancer. So according to the neck ultrasound, we could lose more than 50% of indication to perform fine needle aspiration. So also the neck ultrasound is not very useful to choose nodules that should be punctured because suspected for medullary thyroid cancer. Go ahead. So she came to us, and what we did, we started to talk with the patients. Of course, we asked for a familial history because you know that medullary thyroid cancer can be hereditary. We looked for potential interfering on calcitonin measurement, like, for example, some drugs or other things that patients could intake. We remeasure calcitonin that was confirmed to be high, so the CEA, that is the other serum marker of medullary thyroid cancer. And we perform a neck ultrasound looking also at the laterocervical compartment lymph nodes. Go ahead. So this is the description of the neck ultrasound without suspicious lymph nodes. And we also performed a stimulation test. And I would like to discuss if, in your opinion, it was really necessary.
Yeah, do you do I assume this was a calcium stimulation test, Rossella?
Sorry?
You stimulated with calcium?
With the calcium, yes, with the calcium, because pentagastrin is not more viable since many, many years.
Hey, we seldom do calcitonin stimulation tests for any reason. Probably would not have, definitely would not have done it here with the calcitonin that's already so high. That's far above a false positive rate. So at least in our hands, we would have said, this is medullary until proven otherwise. Dr. Pitoia, any role for calcitonin stim here?
No, we do not use it here, and I agree, I completely agree. I would like to ask Rossella why it was a kind of protocol you usually use for these numbers, or why it was performed.
It is a kind of a protocol because although rarely, but it happened to us to have other neuroendocrine tumors that do not respond to stimulation test. So it is something that at least once we do in our patients. Of course, it is much more important when basal calcitonin is below 100 picogram per milliliter. But we do also in these cases because, as I said, we had some experience with neuroendocrine tumors that did not respond to calcitonin.
Yeah,
Calcium, sorry.
Yeah, things that you see at referral centers that make us practice so different. Okay, so let's talk about what happened to this patient, and then let's look at sort of the big picture cost effectiveness result.
We measure also the calcitonin on the washing fluid of the new nodules, and the calcitonin was really very high, as Dr. Cunningham said before, and Dr. Pitoia. So surgery was planned. I'm sorry, I could not put the histology imaging here. I'm very sorry about this. And she was submitted to total thyroidectomy and central compartment lymph node dissection, because this is at the present the type of surgery that we have to do in these patients. But we could discuss about this.
Okay, let's keep going.
So why there is so much reticence to measure calcitonin in the workup of thyroid nodules? Probably because of the cost. But I would like to conclude this clinical case with a couple of slides showing that, we can go ahead, that indeed there is an advantage, or at least a cost benefit in doing the calcitonin measurement in patients with thyroid nodules. And it seems that it is comparable to the measurement of TSH hormone, colonoscopy, and also mammography screening. And this is another analysis performed by the group of Dr. Randolph, in which they again demonstrated that there is a cost effectiveness in routine calcitonin screening in preoperative diagnosis of medullary thyroid cancer, at least in the United States. There is Dr. Cunningham that would comment, Mike. I don't know if you see the chat.
Yep,
And I need
absolutely.
this. So cost effectiveness analyses need to take into consideration. There's very wide difference in performing these analyses, but for these two studies at least, in my estimation, in terms of figuring out a cost effectiveness analysis for a population, you need to also include the cost of false positives, including papillary thyroid carcinomas and including benign thyroid nodules that have those things. So more to come. Hopefully I can present that work in a few months.
Okay, great. So I don't know if you want.
Yeah. Do your take-home messages. There we go.
No, you do. You can do it, Mike. If you agree with my take-home message, you can do it.
She wants to hear you say it. She wants to hear you say it out loud.
Yeah, I know. It's like I'm just really glad I don't do multinodular goiters anymore, because this data is getting more and more compelling. That thinking about screening with serum calcitonins is not an unreasonable thing. I'm still trying to figure out, do I do it in selective nodules? Do I do it in all nodules? I'm intrigued by this calcitonin washout thing. Could that be a way to sort of look at it? With Carrie, I do worry about all the false positives. Now, to be fair, we used to say that we can't do stimulation tests because we don't have pentagastrin, but that's not true. We have calcium gluconate. We could do it if we wanted to. We did it in the 70s and 80s. So I'm really struggling now. It'll be interesting to see how the new ATA guidelines. I guess my sort of non-scientific thing is medullary is so uncommon, out of all the tumors that we do. If we do it
because you don't look for it.
Well, that's probably true, but they're also not dying of it all over the place. So, and I don't look for papillary either. So I still struggle with that. Carrie, and then Fabian, last sort of comments on sort of where we are and how you see this sort of changing, because this is a lot of compelling data. Carrie?
After reading the data that we discussed about calcium washouts, I'm going to call our thyroid nodule clinic, Rashmi Gartland, who runs a thyroid nodule clinic, and I'm going to start looking into it. I think that is something that would help with the testing characteristics of cytology alone and improving the accuracy. So I think that's important. Again, weighing the pre-test probability of having a medullary thyroid carcinoma versus what Rossella is saying, that maybe we're missing a bunch of little ones. So that's what we need to, that's a great area to study. And Rossella has done a lot of it. I appreciate it. And Fabian, apparently.
Yeah, Dr. Pitoia, finish thoughts on this one for me.
Yeah, I agree that probably measuring calcitonin is not a difficult thing, and it's not expensive, at least in Latin America. And we usually do at least one time in the follow-up. But for example, in this case, it wouldn't have excluded the diagnosis, because if we did once and then a new nodule appeared, it didn't change the diagnosis that it happened here. And so I think for these very in the gray zone, the washout fluids will change also these limitations.
Yeah, I'm trying to look up the cost of a serum calcitonin, but it's probably the cheapest thing you could do of all the things we've been talking about. And probably there'd be no added cost or limited added cost to add it to a FNA.
Expensive. It's about, if you did that in all thyroid nodules that you did a fine needle aspiration, it's a lot over the course of time, because you're doing it on so many people overall. So again, I don't want to hijack the conversation talking about, my hypothesis is that it is cost effective. So, but more to come.
We'll stay tuned.
And interesting, I'm sorry, Mike, you invited me, now I'm going to talk the whole time. The fine needle, it'd be interesting to see, doing a washout of the FNA in the office and not doing cytology. That would save a lot of money. So it's just, I think that's an interesting thought, just doing the washout. If it's less than a centimeter and you're not going to do anything for papillary or follicular, and just sending the washout for a calcitonin. So anyway, I think that's interesting.
I mean, it's compelling that cytology is not as good for medullary. We all know that. It's also compelling that smaller is better in medullary, as far as we know. That's our chance to cure. So that being in this space. Mark, did you sign on there?
Yeah, I just wanted to hats off to that new primary care physician. Perhaps we should that guy or woman, and that's my comment. Great case here.
I knew it was a mistake to call on you. Okay, so let's go ahead and let's look at the anaplastic, and we'll wake up Dr. Wirth and Dr. Shon and get into something that's a little on the other side of the story. So Justin, if you can bring up the anaplastic slides. We've done some anaplastic cases here at the panel over the last year or two, but I thought Rossella's emphasis on this one in terms of the long-term survivors, what I wanted us to focus on in the group, primarily with setting appropriate expectations. Because when I used to see these anaplastic guys, I was not very positive at all, but how that needs to change, particularly in the BRAF patients and the treatment based on the data that we have. So let's sort of focus in on those aspects in terms of thinking about how do we sort of set that appropriate stage for the anaplastics. Rosella?
Yeah. So this is the case of a lady, an old lady, as you can see here, 80 years old when we met her, with a history of multinodular goiter that was diagnosed when she was about 60. She was submitted at that time to several fine needle aspiration of different nodules, and all cytology were benign. Then after 15, 16 years, there was the evidence of a partial autonomy that is something that happened, as you know, in the multinodular goiter, and she started treatment with methimazole. She had some comorbidities like type 2 diabetes, arterial hypertension, and hypercholesterolemia. Go ahead. So she performed in January 2021. She performed an ultrasound in which was demonstrated the presence of a cystic nodule that was stable with respect to other previous ultrasound. And in the left lobe, 2 nodules in the upper and middle nodule were already present in the past, while in the lower third of the lobe, there was a new nodule with irregular margins and rather big because it was more than 3 centimeters. The fine needle aspiration of the new nodule was a Bethesda 6 with low differentiation features already in the cytology. So she was submitted to a CT scan. As you can see here, there was a big mass that was located behind the trachea, and with the irregular margins, and rather big because it was even bigger than what we observed in neck ultrasound, because it was almost 5 centimeters.
Dr. Khorsandi, give me your, I mean, I know this is a thyroid tumor board, that's what this is going to be, but I can see like the whitish thyroid in front of it and this big mass. So what are your initial thoughts when you see something like that?
You know, I don't have other coronal or other images above and below. My first initial, honestly, was that there's a postcricoid, hypopharyngeal, or an esophageal mass, but commonly anaplastics look like this.
Got it. And so, and obviously this is one we're going to way underestimate the size on an ultrasound by its location, right?
Correct.
Okay. All right, so you know you got something bad going on there, Rossella. Where do we go from there?
So what we do regularly in this kind of patients, we check for the airways and for the esophagus to see if there is any type of infiltration. And the bronchoscopy showed the paralysis of the left vocal cord and an infiltration of the trachea. Well, it was not really an infiltration. The doctor could not distinguish between infiltration and compression of the membranous part because the big mass was behind the trachea, so it was pushing the membranous part of the trachea. While the esophageal gastroduodenoscopy did not show any abnormality. So in these cases, we always perform a multidisciplinary meeting with the surgeons and radiotherapists, and from a surgical point of view, it was considered not operable.
Carrie, let me go back one for me. Let me bring you in right here. I've been working with Shaha for more than 20 years, and I have this general rule that nobody's inoperable until Shaha says they're inoperable. What are the things? I mean, because that's such a major thing in this patient. So what are the things that makes this inoperable here, Carrie?
This is tough, and the fact that it's a left vocal cord paralysis, I thought you were going to say right. So that you see your esophagus is way up, almost anterior. So I'd be really worried about esophageal dysfunction and the upper larynx, because the upper larynx, you know, the thoracic surgeons, or in your case, the head and neck guys at Memorial, they're not going to do a tracheal resection way up that high. And also, I have Lori Wirth here, and she's gonna make it all melt away with chemotherapy, I hope. But yes, and an 80-year-old, obviously, end of life conversations involving palliative care early. I think those are really important conversations to start early.
Awesome, very good. And Rossella, you guys went ahead and did a core, I assume?
Say again, sorry?
Yep, go ahead.
Okay. So because the cytology was not very well defined, as you remember, we performed the core needle biopsy, and in this case we obtained the diagnosis of anaplastic carcinoma with the immunohistochemistry positive for TTF1, PAX8, more or less for thyroglobulin, and the Ki67 was quite high, 60%. So this was the final diagnosis of this lady. First approach has resulted from the multidisciplinary meeting was radiotherapy on the neck and upper mediastinum, and in the meantime, we also asked for molecular analysis for this anaplastic thyroid cancer. And the molecular analysis showed the presence of a BRAF V600E mutation, and it was negative for RAS, and also PDL1, that is, you know what it is, was positive in more than 90% of neoplastic cells.
Okay, pause right there for me just a minute. Lori, since this was going to be a long-term survivor, I was expecting the BRAF. The PDL1 positivity in more than 90%, normal, not normal? What are you thinking about that?
Well, so it's uncommon to see that high of a PDL1 staining in anaplastic thyroid cancers, but it's definitely possible and potentially impactful in terms of off-label treatment considerations or thinking about clinical trial opportunities.
And Dr. Hoshan is where she's obviously getting her chemo rads or radiation in the neck to get that under control. In terms of upfront staging for anaplastics, what do you guys normally recommend for like whole body looking for METs, that kind of stuff?
I mean, these are typically very metabolically active on FDG PET, so we would do an FDG PET if it were going to make a difference to what she's had. But I mean, already, I think given she's inoperable and there's this move down some thoughts towards a palliative route, you might question whether you actually make any difference to that. Of course, identifying some, I guess, unexpected sites which might need, other things, palliative radiotherapy or something like that might be helpful.
And does your routine PET
I'm
include the
sorry, can
brain
I
or
ask?
just include from basically the ears down?
Well, we would include the brain, but we would still recommend brain imaging dedicated as well.
And Lori, you're upfront imaging for these guys when they wander in?
Exactly. So we generally would do a PET CT as well. And certainly, that next CT is critical in determining resectability. Sometimes an MRI might give you a neck MRI may give you some resectable, non-resectable help. And then of course, a brain MRI I think is important in all newly diagnosed ATC patients.
So, Lori, let me ask you, if, this lady had a huge tumor and paralyzed cord and invasion. If you had a way to rapidly know BRAF, would you have put her on one of the BRAF inhibitors or still gone to external beam radiation first? How are you sort of in that space there?
Yeah, so that's that is a bit of a dilemma. We do for our anaplastics here, our pathologists will do the immunostaining for BRAF V600E. In their hands, they find it very reliable, sensitive and specific. We do molecular testing as well, but that takes a little while longer. We can do molecular testing for rapid BRAF, but since we have IHC, we don't do that. We just do NGS testing. Just one other thing I wanted to mention about NGS testing and anaplastic before talking about what to do about that BRAF mutation in terms of treatment is, so we also would look at TMB in an anaplastic thyroid cancer case. That's part of our NGS package. So we get it whether or not we ask for it specifically. But in the US, there is a tumor agnostic approval for pembrolizumab in cases with a high tumor mutational burden. Now, what's really interesting, I think, about anaplastics is we don't see high TMBs in all of the patients, as we would expect, I think, to see a very high tumor mutational burden in every anaplastic thyroid cancer. And Mike, your group showed that that's not the case, which is kind of really surprising. But nonetheless, we do see high TMBs more in ATCs than in poorly differentiated or high-grade thyroid cancers, and then of course even more so than in the well-differentiated thyroid cancers.
Dr. Pitoia, how do you get the BRAF staining, or you get BRAF next gen? Where are you guys on this?
It depends on the institution, and I want to call the attention on this diagnosis of the fine needle aspiration biopsy. That is the usual first step that every endocrinologist would do with a thyroid nodule, even for a larger thyroid nodule. And we lose a lot of time. We perform an investigation from our thyroid department that we are going to present now with almost 30 patients, and we have from the beginning of the symptoms until we do the diagnosis, it's almost 5 months. That is a lot of time for anaplastic thyroid cancer. And that is what is happening in Latin America. And then we have like 60% of patients being able to be tested on BRAF. And then from these 60%, only 50% can access to the treatment with dabrafenib and trametinib. So there is a lot of patients that we lose in this pathway that is still very low in Latin America.
Hey, Mark, let me bring you into this. I mean, everybody talks about neoadjuvant these days. That seems to be like the latest thing of oncology and surgery. Any role for, like, if we're in the perfect world and we can find out the BRAF status within a day or two, any role for thinking about using that up front of her as opposed to radiation, or are we anywhere near that now, Mark?
So yes, I mean, in this particular case, it would make a great deal of sense to get started with neoadjuvant therapy and assess response. My assumption here is that there is no evidence of metastatic disease. That's our baseline. So yeah, local control is really of paramount importance. I don't know, Lori may be able to comment on the impact of radiation on response of residual disease to BRAF inhibitors. I don't have that. Mike, you may know that, or Lori?
Lori, any idea on that?
Yeah, so I have had anecdotal experience in treating several patients with anaplastic harboring a BRAF V600E mutation, previously treated with radiation and concurrent chemotherapy. And in the couple of patients that I'm thinking of, we've had really beautiful responses, even in the chemoradiotherapy refractory disease. And one patient had on dabrafenib and trametinib for probably 7 years now, and she is well and remains disease-free. So you can see responses afterwards. Now, I think it would, if this were a younger patient, I think I would be a little bit torn between, whether we should try to go for the best local regional control possible with chemoradiotherapy. The patient isn't going to be able to swallow after chemorads, given the location of the disease. And so you'd have to think about the high likelihood of a permanent G-tube and, possibly significant laryngeal dysfunction as well with chemorads, and weigh that against, about a 60% chance of having a very good durable response with dabrafenib and trametinib. We don't have any head-to-head comparison. The median duration of response to dabrafenib and trametinib is good in anaplastic thyroid cancer, but it's not great. And the traditional approach is chemoradiotherapy in local regionally advanced unresectable disease without distant metastases. So a bit of a dilemma, but I think it's very reasonable to consider, especially in an older woman, but even in a younger patient, upfront treatment with dabrafenib and trametinib. The response rate is almost 60%. So, if you make enough progress that the disease becomes resectable, you can potentially end up with a strategy to cure a patient like this. One other thing I wanted to say about a case like this is just words of warning. So we don't give dabrafenib and trametinib with concurrent radiation. We don't have good safety data. And in the melanoma experience, there was excess toxicity that was encountered with dabrafenib and trametinib and radiation. There is a phase 1 study that is underway through ITOG, taking a look at that. I don't know if this study will enroll enough patients to give us the answer, but hopefully that study will be able to answer that question for us. But definitely something, words of caution.
Dr. Shon, let me bring you back in here to sort of think outside the box a little bit. Some of your research is targeting cell death for imaging and therapy. Do you see a role for that, either like an early response to therapy or picking out? Can you tell us a little bit about that and how you might envision that helping us out in the future?
Yeah, thanks, Mike. I mean, it's very early days yet. We're just in the first proof of concept studies, but we've got a PET radiopharmaceutical that can image cell death in near real time in human tumors. And we think this might be quite interesting, but clearly we've got a lot more work to do on that. But clearly, for neoadjuvant settings, we're currently testing that in a number, not in anaplastic thyroid specifically at the moment, but it might be an early readout of response that might be enabled to, pick the 60% that, for instance, Laurie was talking about that respond, so you don't lose that window for the 40% that don't. And then you can make an early upfront decision as to whether to push on and potentially downstage the patient for surgery or not. It is early days, so watch this space, but we're fairly quietly excited about the project.
That's interesting. Lori, there was a good question from the audience that said, why not just put anaplastic patients on dab-tram and figure out the BRAF status later on? So why not just give it to everybody right up front?
It won't work in anybody who doesn't have a BRAF V600E mutation, but I think that the question was probably implying that the BRAF mutation would be present. And I think that it is, not an unreasonable approach. We just don't have good data on whether in patients who have potentially curable disease without distant metastases, if dabrafenib and trametinib will be superior to chemoradiation. I think certainly if the disease is resectable, surgery should be done first, then adjuvant chemoradiotherapy, because that's the only situation in which we know that patients can indeed be cured.
Okay, Rossella, show me your next 2 slides and let's talk about her long term.
Yeah. So after finishing external radiotherapy, we started the treatment with dabrafenib and trametinib according to the standard protocol of administration. Go ahead. And here is the long-term follow-up of this lady who is still alive. And she got a big reduction of the tumoral mass, as you can see. We also reconsidered, go ahead, the possibility to treat her surgically, but because of the tracheal infiltration, our surgeons said that was not the case, and also because the lesion became stable over the years. Go ahead. And very recently, we checked her, and the tumor is still there. It seems that it doesn't shrink anymore, but she's fine. She has no distant metastases, and the disease appears under control. Go ahead.
I have a question. Did you perform a new fine needle aspiration to determine if this is differentiated now, this tumor, because it's very small and probably?
Interesting questions, but no, we didn't. We didn't. Something that we can do.
Yeah, and Margie, go ahead and say a word there.
Sure, because what you don't know is, this is anaplastic that occurred in a PTC. And so, we've seen cases of, thyroidectomy after BRAF MEK inhibition. And it's kind of amazing. You see the scar-like thing forming. And, it may be that what she has left is a lot of scar tissue and PTC. Just may be.
Yeah.
So Lori, let me take you to the 30,000 feet view. Not necessarily for this patient, but in terms of you setting expectations, it's an anaplastic cancer. Let's say it's localized in the neck, M0, BRAF positivity. What are you telling the families about expected outcomes now, and how did that differ from maybe 10 years ago?
So I think that that's a really great point, Mike, because, the last version of the ATA guidelines before the updated version said immediate palliative care consult for these patients. And these poor people, when they go to the internet and Google their diagnosis of anaplastic thyroid cancer, it's just absolutely devastating for them. And so there's a lot of undoing that we do, and especially if there is a BRAF V600E mutation. And I try to tell patients that this is a very serious diagnosis and a very difficult diagnosis no matter what. However, with a BRAF V600E mutation, there is a little bit of hope that they could have a really good response, and that mutation is druggable, and that we could get lucky, but still we need to be prepared for the worst.
Yeah, Dr. Pitoia, so how do you frame that conversation with folks?
Well, I agree with Lori. I completely agree, and probably this patient has another card we call behind here. Because he has a lot of possibility of being treated or being added with pembrolizumab or any other immunotherapy. So if this patient progresses, probably he has a new additional possibility. And also the age of the patient is also another limitation to think, well, we are giving her a lot of more time with a very nice quality of life.
Okay, Rossella, I got 1 minute and we're going to stop. Give us sort of your take-home thoughts on this patient and the anaplastic. 1 minute.
Yeah, just if you want to look at the imaging, just the next one. I suppose it's exactly. So this is the difference between the beginning and now. This is done very recently. She's fine. She's fine. She's happy, I would say. And we will continue to use dabrafenib and trametinib until the evidence of a progression that I hope will never happen.
Very good. Well, panelists, thank you very much. We covered a lot of ground, from calcitonins to washouts to serum calcitonins to anaplastics. So Rossella, thanks for some wonderful cases and giving us all lots of things to think about. We'll wish everybody a wonderful week, and you can see on the agenda coming up the next Think and Tyro lectures, and we will be taking the 5th of July off for a US holiday, but we look forward to having everybody back on the next discussions. Thanks, panelists. Great job. Bye-bye.